This recording is from Fundamentals Timby, Chapter 31, Bowel Elimination. Learning objectives. Describe the process of defecation. Name 2 components of a bowel elimination assessment. List 5 common alterations in bowel elimination. Name 4 types of constipation. Identify measures within the scope of nursing practice for treating constipation. Identify 2 interventions that promote bowel elimination when it does not occur naturally. Name 2 categories of enema administration. List at least 3 common solutions used in a cleansing enema. Explain the purpose of an oil retention enema. Name 4 nursing activities involved in ostomy care. Large bowel anatomy, beginning in this case with the appendix. This is the large bowel, the cecum, the ascending right colon, the hepatic flexure, the splenic flexure, and across is the transverse colon, and the descending colon from there down towards the sigmoid colon to the rectum and the anus. And in the B picture, it is showing an enlargement of the rectum. The sigmoid colon leads to the rectum, and the rectum has transverse rectal folds and levator ani muscles, internal and anal sphincter muscles, and external anal sphincter muscles all play a role in defecation. Defecation, bowel elimination, is the act of expelling feces or stool from the body. To do so, all structures of the GI tract, especially the components of the large intestine, also referred to as the bowel or colon, must function in a coordinated manner. In the large intestine, 10% or approximately a pint to a quart of water is removed from the remnants of digestion, causing the bowel's contents to become a consolidated mass of residue before being eliminated. Peristalsis means the rhythmic contractions of intestinal smooth muscle that facilitate defecation. Peristalsis moves fiber, water, and nutritional wastes along the ascending, transverse, descending, and sigmoid colon toward the rectum. Peristalsis becomes even more active during eating. This increased peristaltic activity is called the gastrocolic reflex. The gastrocolic reflex usually precedes defecation. Its accelerated wave-like movements, sometimes perceived as slight abdominal cramping, propel stool forward, packing it within the rectum. As the rectum descends, the person feels the urge to defecate. Stool is eventually released when the anal sphincters, the ring-shaped bands of muscles, relax. Performing the Valsalva maneuver, closing the glottis and contracting the pelvic and abdominal muscles to increase abdominal pressure, facilitates this process. Several dietary, physical, social, and emotional factors can influence the bowel's mechanical function. The physiology of the Valsalva maneuver is you're increasing intrathoracic pressure, you're decreasing the venous return at this moment, you're decreasing stroke volume, you're decreasing cardiac output, you're decreasing your blood pressure, you're decreasing your baroreceptors firing, you are decreasing the excitations of the vagal center and decreasing vagal outflow. You're also decreasing inhibition of vasoconstrictor, which is the center of the medulla, and you're decreasing or leading to the increase of sympathetic outflow, which increases your heart rate, increases contractility, and increases vasoconstriction. And the baroreceptor firing decrease causes decreased excitation of the vagal center, which leads to decreased vagal outflow, which leads to increased heart rate, increase in contractility of the heart, and vasoconstriction. Is the following statement true or false? For defecation to take place, all structures of the abdominal tract must function in a coordinated manner. This is false. For defecation to take place, all structures of the gastrointestinal tract, especially the components of the large intestine, must function in a coordinated manner. Assessment of bowel elimination. A comprehensive assessment of bowel elimination involves collecting data about the client's elimination patterns, bowel habits, and the actual characteristics of the feces. Elimination patterns. Because various elimination patterns can be normal, it is essential to determine the client's usual patterns, including the frequency of elimination, the effort required to expel stool, and what elimination aids, if any, he or she uses. Health education regarding bowel elimination includes the following points. Adults should identify their own patterns of bowel regularity, which can range from 3 times a day to 3 times a week. 2. Include daily exercise. 3. Eat high-fiber foods on a regular basis. And 4. Drink 8 to 10 glasses of liquid a day, unless contraindicated, and respond to the urge to defecate as soon as possible. Table 31.1, Common Factors Affecting Bowel Elimination. Types of food consumed. The effect is it influences the color, the odor, the volume, and consistency of stool, and fecal velocity. Fluid intake influences moisture content of stool. Drugs affect slow or speed motility. Emotions can alter bowel motility. Neuromuscular function affects the ability to control rectal muscles. Abdominal muscle tone affects the ability to increase intra-abdominal pressure through the Valsalva maneuver, and opportunity for defecation inhibits or facilitates elimination. Nutrition notes. Fiber is found only in plant foods, most abundantly in wheat bran, whole grains, brown rice, whole wheat bread, oatmeal, dried peas and beans, kidney beans, garbanzo beans, lentils, and the skins and seeds of fresh fruits and vegetables such as pears and apples. Eating a variety of high-fiber foods is recommended. Americans consume approximately half the recommended amount of fiber daily. Tolerance to a high-fiber diet may improve by increasing fiber intake gradually. Adequate fluid is needed for maximum benefit. Stool characteristics. Healthcare providers can obtain objective data about stool characteristics by inspecting the stool or asking the client to describe its appearance. Information that is particularly diagnostic includes stool color, odor, consistency, shape, and unusual components. See Table 31.2 on page 730. In some instances, nurses may independently perform screening tests on stool samples such as those that determine the presence of blood. Nurses then report the results, which can be falsely positive to the physician, who may order more specific laboratory or diagnostic tests. Characteristics of stool. Color. Normal is brown, abnormal is black, clay-colored or tan, yellow, and green. Odor. Consistency. Normal is aromatic, soft, and formed. Abnormal is soft, bulky, hard, dry, watery, paste-like, and foul. Shape is round and full. Abnormal is unformed, flat, pencil-shaped, stone-like. Characteristics. Components. Normal is undigested fiber. Abnormal is worms, blood, pus, and mucus. Testing stool for occult blood. Collect stool within a toilet liner or bedpan. Use of such devices prevents mixing stool with water or urine. Put on gloves and use an applicator stick to collect the specimen. These measures reduce the transmission of microorganisms. Take a sample from the center area of the stool. A sample from here provides more diagnostic value because it is not superficially tainted with blood from local tissue. Apply a thin smear of stool onto the test area supplied with the screening kit. See Figure A on page 731. Correct use of the kit ensures thorough contact with the chemical reagent. Cover the entire test space. Doing so ensures more accurate findings. Place 2 drops of the chemical reagent onto the test space. This promotes a chemical reaction. Wait for 60 seconds. This duration is the time needed for chemical interaction with the stool. Observe for a blue color. This finding indicates that blood is present. Testing for colorectal disorders. The incidence of colorectal cancer increases with age. It is the third most common cancer diagnosed in men and women in the U.S. and the second most common cause of death from cancer. One early sign is a change in bowel elimination patterns and stool characteristics. Blood in the stool, melena, is an abnormal characteristic that may be invisible to the naked eye. Fecal occult blood test. A fecal occult blood test, a self-collected screening test from 3 separate stools, may be obtained by clients to detect heme, Heme, an iron compound in blood present within stool as it passes through the small and large intestine. The fecal occult blood test requires some drug and dietary restrictions prior to collecting samples of stool. See Client and Family Teaching 31.1. Fecal immunochemical test. A fecal immunochemical test, FIT, is the preferred alternative to the fecal occult blood test. The fecal immunochemical test is more specific than an FOBT because it uses antibodies to detect globin, a protein removed from heme, which is present exclusively in the lower intestine. Advantages of the FIT test include that there are no dietary or medication restrictions, only 1 or 2 specimens need to be collected, and it has a high rate of specificity for colorectal cancer. Client and Family Teaching 31.1, page 731. Preparation for collecting a fecal occult blood test. The nurse teaches the client to do the following. Omit taking non-steroidal anti-inflammatory drugs, NSAIDs, such as more than 1 adult aspirin, ibuprofen, or naproxen for 7 days before self-collecting stool. Acetaminophen or Tylenol can be taken as needed. Avoid taking more than 250 milligrams of vitamin C or consuming citrus fruits or juices for 3 days before beginning the test. Eat a high-fiber diet containing whole grains, cooked vegetables, and fruit well. Refrain from eating red meat for 3 days before testing. Poultry and fish are allowed. Do not eat raw turnips, radishes, broccoli, beets, carrots, cauliflower, cucumbers, or mushrooms for 2 to 3 days before the test. Stool DNA test. A self-collected stool test known as Cologuard, approved by the Food and Drug Administration in 2014, is now available to detect mutant DNA from tumor cells present in stool. A client is provided a kit with which to collect and return a single sample. Collection does not require any preparation, diet, or medication changes. Clinical studies have shown a 92% detection of colon cancers as well as precancerous conditions. False positive and false negatives are possible. Positive test results must be followed by an endoscopy examination, which is discussed. Endoscopy examinations. Older asymptomatic adults are advised to have regular colonoscopy examinations, a visual inspection of the interior colon using a flexible lighted endoscope, which is considered the most accurate test for detecting colorectal cancer. Colonoscopy examinations should begin at age 50 and every 10 years thereafter. Those with colorectal cancer risk factors, such as a family history of colorectal cancer or polyps, should undergo colonoscopies earlier and more frequently. An alternative to a colonoscopy is to schedule a flexible sigmoidoscopy, a visual endoscope inspection limited to the sigmoid portion of the large intestine every 5 to 10 years. Other alternatives recommended by the American Cancer Society include a barium enema every 5 years or a colonography, a CT scan without a colonoscope, sometimes referred to as a virtual colonoscopy every 5 years. Common alterations in bowel elimination. Question: is the following statement true or false? Constipation is higher among those whose dietary habits lack adequate fiber. True. Dietary fiber, which becomes undigested cellulose, is important because it attracts water within the bowel, resulting in bulkier stool that is more quickly and easily eliminated. Common alterations in bowel movement. Fecal impaction, large hardened mass of stool interferes with defecation. It's a result of chronic constipation. Flatulence or flatus is an excessive accumulation of intestinal gas. It results from swallowing air while eating or from sluggish peristalsis. Another cause is the gas that forms as a byproduct of bacterial fermentation in the bowel. Vegetables such as cabbage, cucumbers, and onions are commonly known for producing gas. Beans are other gas formers. Eating beans creates intestinal gas because humans lack an enzyme to completely digest its particular form of complex carbohydrate. Regardless of its cause, flatus may be expelled rectally, thus reducing intestinal accumulation and distension. Sometimes, however, this is not sufficient to eliminate the cramping pain or other symptoms. When clients are extremely uncomfortable and ambulating does not eliminate flatus, the nurse may insert a rectal tube to help the gas escape. See Skill 31.1. Diarrhea is the urgent passage of watery stool and commonly is accompanied by abdominal cramping. Simple diarrhea usually begins suddenly and lasts for a short period. Other associated signs and symptoms include nausea and vomiting and blood or mucus in the stools. Usually diarrhea is a means of eliminating an irritating substance such as tainted food or intestinal pathogens. Diarrhea may also result from emotional stress, dietary indiscretions, laxative abuse, or bowel disorders. Resting the bowel temporarily may relieve simple diarrhea. This means that the person drinks clear fluids but avoids solid foods for 12 to 24 hours. Resumed eating begins with bland foods and those low in residue such as bananas, applesauce, and cottage cheese. If diarrhea is not relieved within 24 hours, it is best to consult a physician. Gerontologic considerations. Diarrhea can easily lead to dehydration and electrolyte imbalances, especially hypokalemia, in older adults who tend to have less body fluid reserve than younger people. Nutrition notes. Probiotics are beneficial in some commercial products like yogurt that contain live cultures. These bacteria survive digestion and colonize within the bowel, making bowel's contents more acidic. The lowered intestinal pH creates a hostile environment for unhealthy bacteria. Eating products containing probiotics is believed to regulate and improve elimination, thus reducing symptoms of diarrhea, constipation, intestinal gas, and bloating. Fecal incontinence is the inability to control the elimination of stool. It does not necessarily imply that stool is loose or watery, although that may be the case. In some cases, bowel function is normal, but incontinence results from neurologic changes that impair muscle activity, sensation, or thought processes. Even a fecal impaction may be an underlying cause of incontinence. Incontinence also may occur when a person cannot reach a toilet in time to eliminate, such as after taking a harsh laxative. Chronic fecal incontinence can be devastating socially and emotionally. Clients who cope with chronic fecal incontinence and their families require much support and understanding. They may benefit from teaching that the nurse offers. Client and family teaching. Managing fecal incontinence. 31.2. The nurse teaches the client and the family as follows. Eat regularly and nutritiously. Monitor the pattern of incontinence to determine whether it occurs at a similar time each day. Sit on the toilet or bedside commode before the time elimination tends to occur. Consult the physician about inserting a suppository or administering an enema every 2 to 3 days to establish a pattern for bowel elimination. Use moisture-proof undergarments and absorbent pads to protect clothing and bed linen. Teach caregivers to do the following. Do not imply verbally or non-verbally that the client is to blame for the incontinence or that cleaning him or her is disgusting. Avoid anything that connotes diapering to preserve the client's dignity and self-esteem. Instead, use the word brief. Measures to promote bowel elimination. Nurses commonly use 2 interventions, inserting suppositories and administering enemas to provide elimination when it does not occur naturally or when the bowel must be cleansed for other purposes, such as a prep for surgery, an endoscopy, or X-ray examinations. Inserting a rectal suppository. A suppository is an oval or cone-shaped mass that melts at body temperature, inserted into a body cavity such as the rectum. The most common reason for inserting a suppository is to deliver a drug that will promote the expulsion of feces. Other medications, such as drugs to control vomiting and reduce fever, are also available in suppository form. Pharmacologic considerations. Suppositories are used for both systemic and local effects. Antipyretics are frequently used rectally when fever reduction cannot be managed orally. Constipation can be relieved locally in the rectum when used to soften or stimulate defecation. Medications released from the suppository can have local or systemic effects. Depending on the drug, local effects may include softening and lubricating dry stool, irritating the wall of the rectum and anal canal to stimulate smooth muscle contraction, and liberating carbon dioxide, thus increasing rectal distension and the urge to defecate. Drugs administered in suppository form are chosen when clients have difficulty retaining or absorbing oral medications because of chronic vomiting or an impaired ability to swallow, or it is undesirable to delay defecation while waiting for an oral medication to act. Administering a suppository is a form of medication administration. See Skill 31.2. Administering an enema. An enema introduces a solution into the rectum. Nurses give enemas to cleanse the lower bowel, this is the most common reason, soften feces, expel flatus, soothe irritated mucous membranes, outline the colon during diagnostic x-rays, treat worm and parasite infestations. Cleansing enemas. Cleansing enemas use different types of solution to remove feces from the rectum. Defecation usually occurs within 5 to 15 minutes after administration. Large volume cleansing enemas may create discomfort because they distend the lower bowel. Nurses must administer them cautiously to clients with intestinal disorders such as colitis, which is inflammation of the colon, because large volume enemas may rupture the bowel or cause other secondary complications. In many health agencies and in the home, commercially prepared disposable administration sets have become the method of choice for cleansing the bowel. Their smaller volume makes them less fatiguing and distressing than large volume enemas, and they can be easily self-administered. See Figure 31.4 on page 737. Tap water and normal saline enemas. Tap water and normal saline solutions are preferred for their non-irritating effects, especially for clients with rectal diseases or those being prepared for rectal examinations. Tap water and normal saline appear to have about the same degree of effectiveness for cleansing the bowel. Because tap water is hypotonic, the fluid can be absorbed through the bowel. Consequently, if several enemas are administered in succession, fluid and electrolyte imbalances may occur. Therefore, to ensure client safety, if stool continues to be expelled after the administration of 3 enemas, the nurse consults the physician before administering more. Soap solution enemas. A soap solution enema is a mixture of water and soap. Many disposable enema kits contain an envelope of soap which is mixed with up to a quart 1,000 milliliters of water. If these soap packets are not available, a comparable mixture is 1 milliliter of mild soap, liquid soap, per 200 milliliters of solution, or a ratio of 1 to 200. Therefore, 5 milliliters of soap is added to prepare a volume of 1,000 milliliters. Soap causes chemical irritation of the mucous membranes. Adding too much soap or using strong soap can potentiate the irritating effect. Hypertonic saline enemas. A hypertonic saline, which is sodium phosphate, enema draws fluid from body tissues into the bowel. This increases the fluid volume in the intestine beyond what was originally instilled. The concentrated solution also acts as a local irritant on the mucous membranes. Hypertonic enema solutions are available in commercially prepared disposable containers holding approximately 4 ounces or 120 milliliters of solution. The container, which has a lubricated tip, substitutes for enema equipment and tubing. Retention enemas. A retention enema uses a solution held within the large intestine for a specified period, usually about 30 minutes. Some retention enemas are not expelled at all. One type of retention enema is called an oil retention enema because the fluid instilled is mineral, cottonseed, or olive oil. Oils lubricate and soften the stool so it can be expelled more easily. The oil may come in a pre-filled container similar to those that contain hypertonic saline. If disposable equipment is not available, the nurse lubricates and inserts a 14 to 22 French tube into the rectum. A small funnel or large syringe is attached to the tube, and the nurse instills approximately 100 to 200 milliliters of warmed oil slowly to avoid stimulating an urge to defecate. Premature defecation defeats the purpose of retaining the oil. If you look on page 736, there's a table 31.3, types of cleansing enema solutions. Tap water, amount to use is 500 to 1,000 milliliters. Mechanism of action, it distends the rectum and moistens the stool. Normal saline, you're going to use 500 to 1,000 milliliters. This distends the rectum and moistens the stool. Soap and water, 500 to 1,000 milliliters, distends the rectum, moistens the stool, irritates local tissue. The hypertonic saline is 120 milliliters of solution. This irritates local tissue and draws water into the bowel. And mineral, olive, or cottonseed oil, use 120 to 180 milliliters, and this lubricates and softens stool. Ostomy care. A client with an ostomy is a surgically created opening to the bowel or other structure. This requires additional care for promoting bowel elimination. Two examples of intestinal ostomies are an ileostomy, a surgically created opening to the ileum, and a colostomy, a surgically created opening to a portion of the colon. Materials enter and exit through a stoma, which is the entrance to the opening. Nutrition notes. Because a large amount of fluid, sodium, and potassium are normally absorbed in the colon, the risk of fluid and electrolyte imbalances increases as the length of the remaining colon decreases. Clients with ileostomies are at higher risk of nutritional problems than are clients with colostomies in which some of the colon is retained. Clients with ileostomies are encouraged to consume 8 to 10 glasses of fluid daily to maintain a normal urine output and to minimize the risk of renal calculi, which is stones. Assure clients that excess fluid is excreted through the kidneys, not the stoma. A liberal salt intake may be needed to replenish losses. Ileostomies are placed before the terminal ileum, where vitamin B12 is absorbed. Nasal sprays or parenteral injections of vitamin B12 are necessary to prevent vitamin B12 deficiency anemia. Most persons with an ostomy are also called ostomates, wear an appliance, which is a bag or collection device over the stoma to collect stool. Depending on the type and location of the ostomy, client care may involve providing peristomal care, applying an appliance, draining a continent ileostomy, and for clients with a colostomy, administering irrigations through the stoma. Providing peristomal care. Preventing skin breakdown is a major challenge in ostomy care. Enzymes in the stool can quickly cause excoriation, which is chemical injury to the skin. Washing the stoma and the surrounding skin with mild soap and water and patting it dry can preserve skin integrity. Another way to protect the skin is to apply a barrier substance such as Karaya, Karaya, a plant substance that becomes gelatinous when moistened, and commercial skin preps around the stoma. An enterostomal therapist, a nurse certified in caring for ostomies and related skin problems, may be consulted regarding skin and stomal care. Applying an ostomy appliance. Various appliances are available, but all consist of a pouch for collecting stool and a faceplate or disc that attaches to the abdomen. The stoma protrudes through the opening in the center of the appliance. The pouch fastens into position when pressed over the circular support on the faceplate. Some clients prefer a type that also fastens to an elastic belt worn around the waist. The belt helps to support the weight of the fecal material and prevents the faceplate from being pulled away from the abdomen. The client empties the pouch by releasing the clamp at the bottom. The faceplate usually remains in place for 3 to 5 days unless it becomes loose or causes skin discomfort. Periodically, the client empties the pouch when it is 1/3 to 1/2 full. Otherwise, it may become too heavy and pull the faceplate from the skin. Although design of the equipment varies, almost all types of appliance are changed similarly. Draining a continent ileostomy. A continent ostomy, a surgically created opening that controls the drainage of liquid stool or urine by siphoning it from an internal reservoir, Also is referred to as a cock pouch or a coke pouch after the KOCK, after the surgeon who developed the technique. This type of ostomy requires no appliance. However, the client must drain the accumulating liquid stool or urine approximately every 4 to 6 hours. The client can use a gravity drainage system at night. Refer to Client and Family Teaching 31.3 on page 740. Irrigating a colostomy. Clients with a colostomy whose stool is more solid sometimes require the installation of fluid to promote elimination. Colostomy irrigation involves instilling the solution through the stoma and into the colon, a process similar to administering an enema. The purpose of the irrigation is to remove formed stool, in some cases to regulate the timing of the bowel movements. With regulation, a client with a sigmoid colostomy may not need to wear an appliance. The colostomy irrigation helps to train the bowel. Once the client has eliminated the stool, he or she will expel no more until the next irrigation. This mimics the pattern of natural bowel elimination for most people. Gerontologic considerations. Musculoskeletal disorders such as arthritis of the hands or neurologic disorders may interfere with an older person's ability to care for an ostomy appliance or perform colostomy irrigations. An occupational or enterostomal therapist can offer suggestions for promoting self-care. Also, a wound, ostomy, and continence nurse may be available for consultation and patient teaching. Because of the predictability of bowel elimination, some clients with a sigmoid colostomy feel it is unnecessary to wear an appliance. Client and Family Teaching, Draining a Continent Ileostomy. The nurse teaches the client and the family as follows. Assume a sitting position. Insert a lubricated 22 to 28 French catheter into the stoma. Expect resistance after inserting the tube approximately 2 inches. This is the location of the valve that controls the retention of liquid stool or urine. Gently advance the catheter through the valve at the end of exhalation while coughing or while bearing down on it to pass stool. Lower the external end of the catheter at least 12 inches below the stoma. Direct the end of the catheter into a container or toilet as stool and urine begins to flow. Allow at least 5 to 10 minutes for a complete emptying. Remove the catheter and clean it with warm soapy water. Place the clean catheter in a sealable plastic bag until its next use. Cover the stoma with a gauze square or a large bandage. If the catheter becomes plugged with stool or mucus, bear down as if to have a bowel movement. Rotate the catheter tip inside the stoma. Milk the catheter. If these are not successful, remove the catheter, rinse it, and try again. Notify the physician if these efforts do not result in drainage. Never wait longer than 6 hours without obtaining drainage. And this is draining a continent ileostomy. Nursing Guidelines 31.3, page 738, administering a hypertonic enema solution. Warm the container of solution if it's cold by placing it in a basin or sink of water. Assist the client to a Sims position or use a knee chest position. This promotes gravity distribution of the solution. Wash hands and put on gloves. Remove the cover from the lubricated tip. Cover the tip with additional lubricant. Invert the container and compress the fluid toward the enema tip. So inversion causes air in the container to rise toward the upper end, so you don't insert the air into the patient's bowel. Insert the full length of the tip within the rectum. And when you place the tip into the rectum, you're going to aim towards the belly button. Apply gentle, steady pressure on the solution container for 1 to 2 minutes or until the solution has been completely administered. This method instills a steady stream of solution. Compress the container as the solution instills, similar to what you would do for a tube of toothpaste. Compression provides positive pressure rather than gravity to instill fluid. Encourage the client to retain the solution for 5 to 15 minutes. This promotes effectiveness. Clean the patient and position for comfort. These measures demonstrate concern for the client's well-being. Discard the container, remove gloves, and perform hand hygiene. A continent ileostomy is a cock or coke pouch, K-O-C-H. No appliance is necessary. It's drained every 4 to 6 hours, and it's an actual pouch inside the person's abdomen that collects the fluid. And then the person can remove it through a tube, and then they don't have to do that again for 4 to 6 hours. Nursing measures to treat constipation, primary constipation. Nursing measures to treat constipation. Primary constipation. You need to do an assessment, note the frequency, amount, and texture of the expelled stool. Ask the client about the effort required to eliminate stool. Inquire as to whether the client feels that he or she empties the bowel during stool elimination, and if there's any discomfort in the rectal area. Auscultate bowel sounds daily. Palpate the abdomen to determine if there's any distension. Determine if any of the client's medications are constipating. Ask the client about measures he or she uses to promote bowel elimination and their frequency. Ask the client to describe his or her daily intake of food and fluids, including types of beverages and foods commonly eaten. Explore lifestyle patterns that may interfere with bowel elimination, such as a lack of privacy or lengthy travel that interferes with accessing a toilet when there is a need to eliminate stool. Note if any physical problems may compromise bowel elimination, such as impaired physical mobility or dementia. Nursing diagnosis, constipation related to inadequate dietary habits. Expected outcome, the client will have a bowel movement within 24 hours and list 3 ways to improve the regularity of bowel elimination by 10/25. Interventions, give an oil retention enema as ordered for PRN administration. Give prescribed laxative at bedtime if no bowel movement has occurred. Encourage drinking at least 8 to 10 glasses of fluid per day. Offer prune juice or apple juice. Instruct about high fiber foods, and their intake should be gradually increased as tolerated until the desired effect is achieved. Evaluation of expected outcomes. The client eliminated moderate amount of brown formed stool approximately 6 hours following the administration of the oil retention enema. The client identified a minimum goal of consuming 8 to 12 8-ounce glasses of fluid per day, consuming 8. The client can name sources of fiber such as wheat bran, whole wheat bread, whole grain cereal, fresh fruits and vegetables, dried peas and beans, and nuts. Laxative abuse is very common among older adults and eventually leads to constipation, and effects of prolonged use of mineral oil can do the same thing. This is the end of the slideshow.